Hey guys, welcome to this episode of PRTyCast. A few weeks back, Evan and I sat down with a friend of mine from high school and college, Dr. Brandon Applegate. He is a physical therapist with a background in strength and conditioning. Not surprisingly, we ended up talking for a few hours, so we decided to break up this conversation into two parts. We really enjoyed having a guest in the studio, and we look forward to being able to do more of that in the future. If you guys have a guest or know of anybody that you think would be good for the show, or that you think is in our wheelhouse or availability, let us know. We'll do what we can to reach out and get them on the show. So without further ado, here is part one of our conversation with Dr. Brandon Applegate. Enjoy.
I love it. I learned so much from PTs, and I really do think that, especially this last time, because I haven't been to rehab for any reason in like the last 10 years. But anyway, my PT told me that I was one of the easiest patients that he had to deal with because
you guys do stuff outside of therapy.
Yeah,
right,
and I'm not messing around. I'm taking your advice very serious because I care about my health and I have to train people for a living, so I need my joints. Right. I need to improve. I need to. So I would give him excellent feedback, and we would just go back and forth, and he would say, you know what, his advice ended up being, you can try this, but I don't think you need to, kind of stuff.
Yeah.
And it was awesome. I love talking to him.
Who's your PT?
Oh, it was through the VA.
Okay. I didn't know if you were going somewhere in town here.
No, I can't even remember his name, to be honest.
One thing I forgot to point out earlier. So if that little module over there is your headphone feed, so if it's too quiet, you're the EB, and you can adjust that if you need to, up or down.
That sounds fun right now. So.
Cool. All right, so
I can't believe you don't give me access to that.
I mean, it's just the shortest cable. It is what it is. If you
just don't trust me with technology,
Evan, do you want to adjust the sounds?
I actually don't.
Are your ears too quiet?
No,
I need to boost it.
Totally good.
Years of loud things blowing up around you.
You know what? Surprisingly, I've had no issues with my hearing, man. It's so scary because there are a lot of things to be afraid of, but that was one of my biggest fears was hearing. Just because there's not a lot you can do. In training, we always had some kind of protective gear, but in combat, never.
You mean you didn't run around with Electronic Gear Pro over? And
we tried.
Oh, I'm sure it's just impossible probably at some point.
We tried to use that technology. Although it was impressive, someone could be 100 yards away and you could whisper, "Get on the ground," and they would turn and look at you like, "What the heck are you talking?" They can hear you. So it's impressive and it works. Yeah. But using it in a combat situation, we tried with simulation. It was terrible. Too much crap going on.
Gotcha.
Too much crap going on. You can't,
I wonder if that's gotten better with time.
Man, it's been over a decade, so I would say
right. I mean, it's been a minute since you've been in, so
I have no idea what they're doing now, but I would hope that it's better.
Right. So depending on how this podcast gets pulled out, this is going to either be episode 8 or a series of rapid fires. So who knows? We'll figure that part out. Our audience knows that we are learning as we go. So today, whenever you're listening to this, whether it's part 1, part 10, or whatever, we are sitting down in our first interview with Dr. Brandon Applegate, which has been a friend of mine since I was in high school. I will fully admit it seems a little weird calling him Dr. Brandon Applegate. But so I'm sure Evan and I will have questions for you, man. But if you want to just kind of a little bit, about yourself, where you grew up, who you are, what kind of schooling you've gone through,
Gotcha. What
you're doing now.
Well, I am a physical I don't know where to look.
Right. Just imagine the camera's not there. Just talk to us.
So I'm Dr. Brandon Applegate. I'm a physical therapist. I currently work over in Terre Haute, Indiana. But I went to ISU, starting at ISU in 2012, and then I was there for 7 years. I got my bachelor's in exercise science in 2016. And then I stuck around for PT school, and it was the second class to go through, so it was a relatively new program. But I got my doctorate of physical therapy in 2019.
Perfect timing.
Yeah.
Came right out of school, right?
Right out of
COVID.
school. Worked for about 5 months and then got furloughed. So, but I guess that's a better situation than, people who are in PT school right now. But
That's for sure.
I got my CSCS through the NSCA in July, I think, of 2019. So I did that before I took my board exam. And I currently work in outpatient orthopedics, so work with a lot of like older people with low back pain or knee pain, shoulder pain.
Pain in general.
Yeah, I do a lot of stuff with balance. And then I have my my own practice, which is performance physical therapy. And it's a gym-based physical therapy. So I'm actually based out of a CrossFit gym in Terre Haute. But that's where I do like a lot of the things that I enjoy the most is in my gym-based stuff. So
nice. One note I will say, pull that mic just a smidge away from you.
Oh, way.
Yeah. So you want just a little distance.
Gotcha. So you don't hear all my
all the breathing sounds. Like I found it's one of the hardest things to do is to remember like to actually breathe and remember talking to the mic, of course, but like I'll be talking and I'll get excited and then I'll be like,
well,
I have to lean back out of the mic and take like several deep breaths.
Truth be told, I breathe through my nose all the time, so it's so easy for me to do that. But you also have, haven't you had your nose broken a few times, MMA and training and stuff like that?
Three broken noses before
you can't breathe.
I had a deviated septum so bad I had like 90-something% blocked on one side, 80 on the other side, and like even still, they did the surgery and it's better. I mean, I'd say like probably 50% better. Like I've noticed that I can actually breathe. I don't wake up every morning with like a sore throat from breathing in my mouth. Right, exactly. Like I don't snore as bad as I used to.
Whenever you told me about you have a hard time breathing, I thought, why can't you calm your breathing through your nose? And I thought, you can't.
Well, I mean, and the thing is that I didn't get that surgery until I was in college. And so like I lived my entire life being a mouth breather and just had to figure it out. And so then you get to college and get it fixed, and I'm just not used to doing it.
I don't want to interrupt the introduction, but I jotted down a note. I want to ask this: how much do you think? The first thing you said was dealing with older people with pain. Mm-hmm. How much do you think that your strength and conditioning background assists with maybe the perspective of how to get someone out of pain versus just the rehab side?
I think with like the strength and conditioning background, there's a lot of like education.
It's a fairly loaded question. But.
Yeah, I feel like there's a lot of education that you don't get in PT school about like progressive tissue loading that comes from that strength and conditioning background. Mm-hmm. And I think that's something that like a lot of PTs in rehab don't have.
Talking about something a little more than just a band pulling this way.
Yes.
Or a 1 pound dumbbell.
So like you'll hear PT saying like, think functional movements and like things like that. But then you go in the clinic and the exercise equipment is very, very limited. Yeah. You have bands and like 10-pound dumbbells.
Maybe a few stairs.
Yeah. So like the amount of like tissue loading you can do, it's limited how far you can progress somebody, which limits their potential for like getting better. Mm-hmm. Like there are a lot of things that go into pain. So that's just like one aspect of it. But I do think the strength and conditioning background helps a lot. Cause like I get looks whenever whenever I'm like teaching my like 60 or 70-year-old patients how to deadlift or like, hip hinge efficiently. Yeah. Like OSHA, everybody hears the like lift with your legs, not your back phrase. It's like if you do an efficient deadlifting posture, it's safe and it's not going to be painful, and people need to learn how to do that because not everybody has the hip mobility to, squat all the way down.
Right. Yeah. Right. Yeah. The most perfect loaded deadlift that you can do with your own, I guess, functional mobility. Yeah. But I still hear that all the time. Lift with your legs, not your back.
Yeah.
How about both?
Right. That's this like people think that it's going to hurt them if they lift like with a deadlift posture. It's like no, it's not. Like you're
teaching people how to like not squat a deadlift is one of the hardest things to do. Especially trap bar.
I don't think it's necessarily like a PT putting fear into someone at all. But I hear so many stories about doctors putting fear in their patients of, don't do this because of whatever reason. If you lift more than 5 pounds, if you lift more than 20 pounds, or if you do this outside of this surgery, you're going to be so frail. Oh my gosh. But it really bothers me whenever I hear people say that, because from that point on, it limits, at least from a mental capacity, any kind of progression. Or they may not think it's safe at all whatsoever to even dive into that area.
That is a large component of pain. So like the pain, part of the reason that we have this problem is that when we talk about pain, they operated off of like a very biomechanical model, meaning like structurally, like if it looked bad structurally, that's why you were in pain. So that's why like a lot of doctors will order routine imaging for people who have like non-specific low back pain, that it's a chronic condition. They've had it for months to years. And we just know based off of the research that imaging for chronic conditions is very, very poor in relation to pain. So it's like, why do we continue to do or why do they continue to get these imaging studies done when we know they're not beneficial at all? And it actually impedes the patient's progress or ability to get better. They know, like based off of the research, if somebody comes in with back pain and they get a routine X-ray or MRI, their chances of getting better with therapy are drastically less than somebody who just got sent to therapy.
So because
because now there's a biopsychosocial model for pain, and there's what happens when they get those imaging studies and they're told, hey, you have degenerative disc disease, or hey, you have stenosis, or there's no space between your vertebrae anymore. Like that kind of stuff. That leads to fear avoidant behaviors. So they quit getting into positions where, those back muscles and lower extremity muscles are active, which that's going to facilitate pain because our bodies need to move. Like movement is good. Motion's lotion.
Movement is medicine.
There you go.
I don't have the appropriate background, but whenever someone says something about an MRI to me, I think it's still just a picture.
Right.
That's all it is.
It doesn't look at how you're moving. Like that is it. You're laying on a table.
Yeah.
How is that representative of you moving? It's not.
Right. And it's not it's a snapshot image of what's going on at that moment in time. And the thing is like, if I would imagine, and this has been backed up by other things, is like every single person, if you did an MRI, has either a little bit of a compressed disc or a slight bulge here and there. And it's
called the Brinjiki study. So there is a table. If you Google Brinjiki study, it'll be a table with they have age like every 10 years, and then they have a list of conditions on the side. So it'll say like disc degeneration, facet, arthropathies.
Like the likelihood and the chances are like go up with age, or
basically it's like people age 50 and above, about 85% and more are going to have degenerative disc disease. They're going to have decreased height between the vertebrae. They're going to have reduced disc signal. They're going to have dehydrated discs. They're going to have all of these like findings on an MRI. And in that particular study, it was a meta-analysis. So they looked at all these other studies that had been done, and all of the people on that table were asymptomatic for pain, meaning they had these findings, but they had no pain. So 85% of people age 50 and older are going to have degenerative disc disease and not have any pain. Like they wouldn't know they had it until they had the MRI.
Until you told them.
Yeah.
Yep. And exactly. And that's the thing, is that then when some of these signs, they're told that like you said, it creates this fear loop, and then they get stuck in it, and then it just ends up creating the problem that they didn't even have beforehand, or it makes it worse. And that's something that we run into a lot, is that people will come in and, well, my doctor says I can only lift 5 pounds. Good luck living your life.
You gotta start asking your doctors, like, when's the last time you worked out?
Right. Well,
like,
and so this is
seriously, it's not a like. It's sad that that's a question. I mean, their schedules.
That's the promo right there.
Their schedules are like so jam packed. Like they have to see so many patients in a day. Like I get like not having the energy to want to work out or something like that, but they don't always have that background either. So I still think it's a valid question.
5-minute smoke break whenever you can, eating potato chips and sandwiches when you can.
Yeah.
And then
this is the thing that blows my mind. And I don't it's kind of a little bit of like everybody kind of learning how to stay in their lane, but we need to work together instead of making it exclusive. So a lot of times, whether you're a doctor or a nurse, they are incredibly specialized in what they know, and they know, kind of a mile deep, inch wide in terms of their knowledge. So they've got a ton of knowledge on a specific topic or specific, section, but they a lot of times don't have, the strength and conditioning background or any knowledge of that. And so their thought is, okay, let's either medicate, let's operate, let's send them to PT, or something along those lines. And they don't have a ton of information on either practical information just because they never had to experience it, or they just, and the thing is when you get a doctor who does train, who works out, like the chiropractor over here in town that is like a power lifter, like he's able to provide a more complete picture to that person. And I know that like when I've had clients come in and, there's issues going on, if the doctor or PT has said a certain thing, if I can, if I know who they are and the patient's okay with it, the client's okay with it, I'll give that guy a call. And hey, this is what's going on. This is my background. This is who I am. This is what I'm doing. Can we work together to help provide the best service for this client? Because I know they're not going to do their at-home stuff, because probably I don't think anybody ever does.
Oh, let me tell you something about
Nobody does their homework?
Okay, so they did there's studies for everything.
Right,
So
right.
They looked at compliance rates in, I think this population was age like 40 to 65. Because that's like,
so responsible adults.
That's generally what your outpatient population is most people age 40 to 65 with musculoskeletal disorders. But they gave them one exercise. The compliance rate was 73%. Added in an additional exercise. And guess what the compliance rate dropped to?
Like 10.
13%.
Oh my gosh.
So when I give my home exercise programs, I give one exercise.
That's all you can do.
Yeah.
If you give two, they may not even do one.
They're not going to do it. And I tell them, do this one exercise twice a day, just so that they'll do it one time a day.
Right.
It's not like I just know that this is what's going to happen. So I'm not going to, try to give them this laundry list of things to do when they're just not going to do it. So,
yeah.
And the other thing that's helpful too, when there is that communication from client or from like strength professional, whether it's a personal trainer or a strength conditioning coach to the PT, athletic trainer, doctor, is that like then inside of that conversation you can be like, okay, what can they actually tolerate? What can they do? Because sometimes like the client will tell you, well, I can do these things. And you talk to the PT and you're like, well, we're recommending these things. Okay, cool. Let's find the happy medium, and then what can we do to make them better? And then like actually having the conversation with your client. What'd you guys do in PT today? Let's not double up on that. Let's make sure that we're smart with how we program our stuff. And then what I would do is in the last 10, 15, 20 minutes of the workout, depending on what we're doing that day and depending on the injury, hey man, go ahead and grab that band over there. Do your at-home stuff. You got time. Do it right now. Yeah. And I'll sit there and watch them.
that like what we're kind of talking about right now is what my like last podcast episode was over, is like building those relationships with like local personal trainers and strength coaches so that you have that network that you can refer your patients out to. Because like my whole goal is creating like this like longevity of care, or being able to streamline somebody's care. I don't think rehab stops at PT. It doesn't actually ever stop. It's the ongoing like health and wellness, making sure that you're working out a couple times a week, doing just some basic strength movements, but if you can get them established with a personal trainer or a strength coach that you know and trust, that goes a long way, because the patient's going to be like, oh, like there's this communication there. They're already going to know what's going on before I even get there. Yeah. Like I don't have to worry about doing something that's going to, potentially put me back in pain. It's just, those relationships go a long way for your patients too.
I think this kind of goes with how I feel about referring out as well. I think it takes a great deal of almost experience and confidence to know what you know and say you need to go see a chiropractor.
And stay in your lane.
Yeah, you should probably
takes a lot of confidence.
Go to your PT or give somebody a call, because this is outside my scope. But as far as having clients that are in PT at the moment, I take that very serious, because what do I know that you don't know?
See, like
as far as rehabbing that specific person. So what do I think that I could do better then your specific time with them, assessments, and protocols that you need to be doing. So as a trainer, you need to take a step back if someone is in PT at that moment. Big time. You can train other areas, but I honestly view it as off limits until you're done with rehab, and then I'll take where you are then, and then we'll progress. Just because, you don't want the dose to be too great.
What I do, so I actually have some patients that I like send to Brandon Smitley.
Yeah.
And I'm kind of assessing where they're at, like tolerance for higher level movements. Not necessarily when they come to therapy, we're just doing more at home exercises, because I know that what they're doing in the gym is enough on the strength side. Like their time spent with me can be better spent doing more assessments. Like that way I usually see them at a reduced frequency. So I'll see them like once every 2 weeks or something like that.
Yeah.
So I can kind of keep tabs on how they're progressing. And then like there's that line of communication between me and Brandon. So I can say like, and he knows, and I trust him too, to progress people with their exercises. Like, I don't know why, but PTs think that like they're the only ones who can prescribe exercise.
Yeah.
I actually had that. So one of the clients that we worked with had an ACL surgery, and his doctor, recommended PT, and so they went to PT. Went through several weeks of it and went back for a checkup, and the doctor basically said, "You're so far behind your progress. You should be at this level." What have you been doing? And so then the PT basically and the doctor kind of had it out, and essentially what ended up happening was, and I had been training this kid before, and essentially what happened was the conversation then got put on, hey, can you Jared, can you guys get him? Can we get him on a faster track? Can we get him back up to speed? And we did. We started basically just super basic, what we were allowed to do, super high box squats with the belt squat, doing some things like that, trying to load and get everything stronger. We did a lot of, and this is something we can talk about more because I think it's super cool. But basically did a lot of single leg work on the leg that was really good, and working on that. I think the way that basically the cross education kind of style, however you look at it. And it's like, and that stuff helped a ton. And when he went back to his doctor, he was back on, he'd only been working with me for, I think 3 weeks at that point, coming back. And he was already back to where he was supposed to be and had caught back up with the progress that he had lost just through just super basic, super, simple strength work, and actually working on using the muscles and not, because he was getting basically was getting stretched and doing some walking and wasn't really doing anything in PT. And that was an unfortunate experience with that specific PT. And it had nothing to do with like the PT world in general, because I've had really great experiences with other PTs that I've had conversations with, but I ended up trying to reach out to this one, and they didn't want to progress him any further.
I wonder what their
it was a weird
experience
disconnect
was with athletes. Maybe if someone tears an ACL, that's an appropriate approach for someone maybe a little bit older, or depending on like what they do during their daily life. But for an athlete, I mean, you eventually have to get them stronger.
And I had the luxury of like at Indiana State, like I got stuck with, like when I was an intern, I had the freshman incoming junior JUCO transfers, and I had the injured kids. One of the guys that was an injured kid was an ACL repair. And so the AT would come to me, hey, this is what we can do. And it was really aggressive, but he's a D1 athlete, D1A. But like you said, dealing with athletes is entirely different than it is dealing with, with an older client.
I would actually feel a lot more confident if I had a PT who was pretty aggressive that had experience, because then I would know where my limitations are versus just guessing as a coach, because honestly, that's what you're doing. You're guessing. So if a PT had some very good guidelines for you as a coach after PT, that would be, best case scenario.
Yeah, there are like the goals of rehab for like ACL reconstructions and things like that. They change as the timeline progresses. So really, it depends on like where the person is at in their like rehab process. But I would say for the most part, for surgery purposes, PT's goals are to restore motion. Like they can strengthen later.
Yeah.
If you don't address the mobility side of things first, they're not going to get that mobility back if you extend out of that timeline, because
Makes sense.
there's like the tissue
window's
healing cascade.
closing.
Yeah. So there's this higher like movement hierarchy, and mobility is at the top. So like if you don't get somebody mobile, you don't return like full knee extension, because that's important for like high speed running and things like that. Like you're not going to get that back. And if this is an athlete and they've all of a sudden now they don't have that ability to extend their knee, they're going to decline in performance later on. So it's like maybe the PT was super focused on mobility early on, and kind of said, hey, we can deal with the strengthening later, because that's my big thing too, is like especially with ACLs, because I have that relationship with Brandon. I can push them that way when it gets to that point,
Right.
But yeah. So like I'm a heavy manual therapist. Like I do a lot of manual therapy with my patients. Every visit they're getting manual therapy, but that's in conjunction with exercises too. But
it takes some of the burden off of you, because you have a good relationship with Brandon. You have a good relationship with who is their strength coach, and so that helps. I imagine that would help a ton.
And like timelines for strengthening. So with ACLs, a year out, they're still not to the level of, or like strength wise, unilateral strengthening, they're still not to the level of the contralateral limb.
Can you repeat that?
Yeah, a year out, ACL, people who've had ACLRs, 1 year later, they're still around like 70% maximum voluntary contraction.
I almost want you to repeat it again, so it sinks in a little bit.
Yeah.
But
look, guys, that's the reason we brought somebody on that knows more than us.
If
it doesn't sound like I know more than you. You guys are already talking about it.
if you're in the
we talk about a lot of things that we joked about this the other day, that there are things that we know through research that we're just interested in, or just the things that we've run into and kind of had to learn that we don't necessarily, I guess, allegedly, like quote unquote, have any business knowing. That like are outside of our lane.
Time. We have no business knowing some of that.
Right. There are some things that's like, look, we got to know it because we need to know it. But like at the same time, it's good having somebody that knows, and having a relationship with somebody that knows, hey, during this phase, these are the things we should be looking at and focused on. So
I have a question about, you mentioned that your main objective would probably be range of motion first, right? Because the window's going to close.
Yeah.
And if you know a trainer or a coach that you can push that person to develop the strength later, if you're in a more of a clinical setting versus your own thing that you got going on, what's good enough as far as range of motion before I send you on your way? Is it a time specific thing? Is it an insurance specific thing? Because I don't know how many times I get clients that whenever they come see me, I'm like, your range of motion is still terrible.
Yeah.
And then that pressure is put on me. Like it's kind of hard, like you working on range of motion and trusting that the strength will come later versus trying to build strength while building range of motion. It may be a little bit tougher. But what I would love to know is when you send someone on their way, if it's, do you get to decide that in a clinical setting?
Yeah. So as far as like range of motion goes, so for all of your joints, we have what are called capsular patterns. So capsular patterns means like this. So for the knee, it's simple because there's extension and flexion. It's a hinge. It only goes in two ways. So like extension is the one that you'll have the biggest. Yeah, supposed to just go two ways. But extension is the one that you'll have the biggest limitation in. So that's why we want to get that one first. So like initial stages of rehab, I'm not super worried about getting the knee to bend as much as I am getting the knee to be completely straight. And we want to match it to the total arc of movement of the other limb. So like if somebody has, 3 or 4 degrees of hyperextension.
You know what baseline is. And
yeah. So instead of like, I think I might be getting like too much into like PT stuff, but like
it's okay. That's kind of what I wanted you to do.
Okay. We do like, we'll take range of motion measurements with the GONI at each visit, typically when they're acute and after surgery and things like that, just to make sure they're not regressing. But let's say you had surgery on the right leg and we're taking measurements on the left leg. So let's say that person has 135 degrees of flexion and then 5 degrees of hyperextension. So that total arc of movement is 140 degrees. So you might be working on the contralateral limb or the surgery limb, and you might get 140 degrees of knee flexion and then 0 degrees of extension. That's fine because the total arc of movement is similar side to side. So you don't have to like push them through to get that extra 5 degrees of hyperextension.
Right.
I know I said like hyperextension is important or full extension is important for high-speed running and high-speed gait, things like that.
Mm-hmm.
But we're really looking at total arc of movement, and that's the same for the shoulder too. Kind of lost track of where I was going here. As far as when do we progress them to strength? So I am still doing some like low-level like exercise with the mobility stuff that I have them doing. Most of them, they're coming off of a nerve block. So a lot of times we have like the quad is just asleep because they're still kind of waiting for that nerve block to wear off.
So we know what a nerve block is, but just short explain what it is.
So for ACLRs, they'll either do like an adductor nerve block or a femoral nerve block. So your femoral nerve is the one that innervates the quad, so the big muscles on top of the thigh, and the area of skin, like sensation-wise, for the thigh. So they do that so that you're not in a crazy amount of pain after the surgery. Typically, if you have a femoral nerve block, you have a harder time getting that quad activation back. So I always like it when they do an adductor nerve block. It's just a different nerve that they do the block on, but because you don't have an adductor nerve. But I don't know why it's called an adductor nerve block. But
I don't know. I'll have to bring a surgeon on to answer that question next time.
There you go. But so like I'll have them doing what are called quad sets. So think about like if you were just trying to straighten your knee out as much as you can while you're sitting down. I'll have them doing that. Straight leg raises. They're low level exercises. Like somebody they didn't lose all their strength in a matter of 3 weeks. Like some of it is just neuromuscular coordination, things like that. Like you got to get the muscles to fire again. So that's a lot of the initial stages of rehab. There are like certain points where we will get to like doing long arc quads. So they're sitting at the table and they're straightening the knee out with some weight or like an ankle weight.
Ankle weight, yeah.
Yeah, we do a lot of closed chain exercises early on because of the increased load of the ACL if you're doing open chain exercises. But as far as like timelines go, usually, again, it also depends on how the patient progresses. Usually at like 12 weeks, they are at least jogging at that point. And that's usually when I will send them out for higher level strengthening. And I kind of make sure that I stay in contact with the coaches because there are like timelines that we don't want to do too much too fast because you can overload the tissue and then risk the re-injury.
Yeah.
But yeah, sometimes like we'll be doing the strengthening. We haven't met a timeline yet, but their level is beyond the equipment that we have in the clinic. Yeah. So it's kind of like what's the point, you know? So they need to go somewhere else to start doing some strengthening. But
and I think that and this is probably something we'll begin to see more and more, I hope, and is partnerships like what you guys have, and even like in-house physical therapists where you've got like a physical therapy clinic, if you will, it either sharing a space or, right next door to, so that you've got kind of you've got the approach from both sides, and it really leads to a natural progression of rolling.
A faster natural progression.
Right. Right. And the thing is that if you truly share the space and you can use it all, it's like, okay, well then there is no limit to how far I can go, with what I'm doing. I can PT and do my exercises, and then as soon as they're ready to progress, if I have access to a full gym, I can just, okay, let's move up some weight, let's do this. And that's oh man, I'm gonna blank on what this guy's account is. Yep, I just did Squat University.
Aaron.
I don't remember his name.
Yeah, I don't remember his name.
Horschig, Aaron Horschig.
Yeah, the dude's got
Yeah, he has his
full
I
access.
think he works in a clinic and then he has his own home space, right? Yeah.
right, and does a lot of that kind of stuff, blending the two together, and does a really good job of explaining things and breaking things down and blending your PT and your strength and conditioning and making sure that they kind of work in harmony.
I like his approach because he doesn't have any special equipment at all whatsoever. Usually he has a lot of athletes and they use a barbell, and he takes his assessments and then he tries to transfer everything to make sure that it's appropriate for their sport or their size, wherever they're feeling the most pain or whatever. Yeah. Versus, having super specific, super expensive machines to do, some kind of isolation work.
Yeah. And like a lot of his people are lifters. Like imagine like, you're able to deadlift like 400, 500 pounds and you're having some back pain. And then you go to like an ATI or sorry, I don't know if we're name dropping here or not, but
You're good.
you go to like
we're not sponsored by them.
Yeah. You go to like a corporate PT chain where again, you're
never going to go back because it's
right. They give you like, yes, exactly. Right. That is what I hate about PT is the fact that there are so many clinics like that. Like that is just when somebody says PT, that's the first thing that they think is one of these outpatient, like corporate outpatient chains. And
yeah, we're literally the heaviest thing you can ever get your hands on is, like you said, maybe 10 pounds.
Like I have a 25-pound kettlebell in the clinic now, and that took months to get. Like I literally asked to order a 25-pound kettlebell, and they're like, "What do you need that for?" Like,
who cares?
I have a. Well, the first time I said I need a 5, 10, 15, 20, and 25-pound kettlebell,
and that was too much.
And he was like, "Well, which one do you think you'll use the most?" I was
like, all of them. It depends on
like,
the situation.
Like, if somebody's stronger or somebody's weaker, like I need to have that variability. So that's like me saying like, which dumbbell are you going to use the most?
Right.
Yeah.
Yeah, no, oh man, I can't imagine. It's hard enough. I mean, even just buying equipment for the gym, trying to think about, okay, what do we need? What can we get away with? And, there are things that if you're going to have a full service, facility, whether it's a PT clinic or a gym, and you're going to serve a wide range of people, you've got to have a little bit of everything. You've got to have a wide range of options, because if you don't, you then, or if you that or you got to be really, really creative. Or a combo of the two, because if you don't have all the tools, then you're potentially leaving some progress on the table.
So it also depends on how good you are with what tools you have. Like you mentioned manual therapy several times. My guess is you're pretty good at that stuff, and you probably have to use it because the tools you have kind of suck.
Well, in like the PT world, there are like people who are like, "Oh, manual therapy is a sham," and then because there's just like there are like.
I think of that as such a skill. I personally.
Yeah, like I'm trying to think of a good way to explain. So there's different like schools of thought for PT. Like I'm what I would consider a Maitland therapist. So Maitland is heavily influenced by manual therapy. There's like McKenzie therapists. Those are the people that like you go for back pain and they tell you to bend backwards a bunch of times, which like for back pain, there are certain times when those are like the indicated set of exercises to do. We have what's called like treatment-based classification. So there's like 4 subgroups that patients fall into based off of their presentation. And if they have a directional preference, that's when you go, okay, we're doing McKenzie extensions or Wilson's flexions. Just depends on the patient. So the problem is you get therapists who are like, oh, I'm a Maitland therapist, and they only do manual therapy.
They only identify as that one.
Right. So then when your only tool is a hammer, everything looks like a nail.
Yeah.
And it doesn't work. You have to have like multiple like tools that you're using here.
Yeah.
It's like, well, I do concurrent training, so therefore everybody has to do concurrent training.
Yeah.
Come on now. No. Like you gotta have the availability and the ability to look around and try other things and and to experiment.
But yeah, I do a lot of like hands-on stuff. I do a lot of dry needling. I do a lot of like spine manipulations, so that like getting your neck cracked or back cracked. I do a little bit of cupping. Not a huge fan of cupping, but if the patient likes it and they feel better, I stick with it. But Yeah. What
I
else?
think it's more of a
We all do that too sometimes with like, direct bicep training with high school athletes. It's like,
just kind of giving to if they
get
want
get
it.
the gun
Yeah.
work in, get in there,
There's
Hoss.
definitely that like
There's some benefit.
that psychosocial aspect of it.
Yeah.
Like if they think it feels
That's
better,
improving their recovery
Yes.
versus the
yeah. Like I don't
Gotcha.
care if it says it works or not. Like
Yeah, there's a
it's a
huge
small.
there's
really
a
small.
huge connection between like your mental attitude in recovery and in training and like in the actual physiological response to that. Like if you don't think it's working, it's gonna not work. Like it's at least not work as well. And there is a huge like just the attitude with which you attack, your rehab or your training, and that makes a huge difference.
there's a good account to follow. It's called ICE Physio. It's the Institute for Clinical Excellence. But they basically post at least once or twice a week, like a review of literature. And for back and neck pain, they like surveyed patients. It's like, what types of things would you think would feel good or would you want in therapy? And like 70% of people said they wanted like a spine manipulation where you get your back popped or your neck popped. So it's like, why are we not doing that? Also, there's like research to show that the spine manipulations and mobilizations, things like that, they're beneficial at reducing pain. So it's like, why are we not doing it? From a PT side of things, there's some like legislative issues that we have to deal with. Like I can't just go and manipulate a patient without having a physician or a chiropractor's signature on the plan of care, which that's a topic for another time. I get frustrated with that one because like if I have the ability to do that and it helps the patient, why am I being restricted to do that when it's part of our like practice act? Like we
Right, it's
are
within your
skilled-
scope.
Yeah, we're skilled
Right.
in doing it. Like it's something that a lot of PTs don't do. One, because like I don't know why, like not all schools teach it. Like I'm pretty thankful that I went to ISU because I had a Maitland therapist as a professor, and he does a lot of spine manipulation, mobilizations with movement, does a lot of dry needling, and so I got that exposure. And then I'd go on clinicals and I'd ask about manipulations, and they're like, "Nah, those don't work." I'm like, "Yes, they do," but all right.
Yeah, and we find that in the strength conditioning world though too. Like there's all kinds of things that have like either a stigma attached to it, is either you have to do this or you can't in any way do this. And like the thing is that like we talked about this at length in probably the last episode of Rapid Fire. It was just the idea of like a barbell back squat. We had somebody comment, and this was at the old facility we worked at.
Oh yeah,
we had somebody do
you
it.
love it.
We had an older lady
In her 80s.
that had recovered from when she came to us had a back brace on, and a cane or a walker.
No, I don't know.
No, she didn't. My bad.
think
She had a
she
back
just had a
brace.
back
She had a back
brace,
brace,
yeah.
and she was incredibly slow. Like, and she had to be helped around. Her husband had to dress her. Like, couldn't do anything on her own.
Mhm.
And through the style of training that Evan did, like I didn't have much to do with this process, but that Evan did, got her to a point where she didn't need the back brace anymore. She was able to get up, dress herself. She got to a point of being able to go out and shop for herself, which is something she hadn't been able to do in like 10, 15 years. And so there was a video that we posted, or maybe it was just a still shot of her on the belt squat,
I think it was just a shot.
doing a high box squat on the belt squat, super high, and just working on those kinds of things. And so this individual that claimed to have some credibility made a comment about like, this exercise not being helpful because we need to work on mobility and range of motion first in terms of getting her to like an A to G, or super low, below parallel squat,
Yeah.
in the hopes of progressing to a
I said
barbell.
butts to boots for a more.
Right. Yeah.
more
Getting her to basically trying to get her to a barbell back squat. And I'm going,
Also, the barbell back squat specifically being a foundational exercise.
right. And that's
versus-
what the argument was, is that he was like, this is a foundational exercise. And so like at the time I was the one
based
running
on
our
what
social
foundation?
media.
I mean, it would have.
Having a response back to that, I was like, man, I typed
Yeah,
that thing out like
bar's
16
just a tool.
times. 100%.
Yeah, I thought this lady can't comb her hair, and you want her to try and
Barbell back
grab a
squat.
barbell.
Yeah.
Like-
How many?
Okay.
How many ladies have you trained, and how many of them enjoy putting solid steel on their back?
Mhm.
Yeah, there are some of us that are just
that
weirdos that
haven't
love
had
pain.
the athletic background of already doing that for years and years and
You gotta
years.
get that like manta ray pad thing.
Oh, there you go.
Yeah.
It throws the angle out. It does all kinds of weird things. That's the thing though, is like, and that was the argument the discussion we had last time was just like, there is no, in the PT world, in the strength and conditioning world, I'm not going to say there's no rules, because there are rules obviously, but like, if you find there's nothing that you have to do and there's nothing that you can't do, if it fits what your client needs and it fits what your client is able to do and it helps them progress towards the goal that they have. Like there was a post, and I can't even remember who it was. It might have been Mike Boyle. One of his guys had like a 70-year-old guy doing I think it was like a 6 or a 12-inch box jump. And it was an older adult, but it was a ballistic movement that he had worked his way up to, that he knew how to do, that he was comfortable and he enjoyed doing. And it helped him, get along with what he was doing. And it's like, to somebody that doesn't have the background or the experience, that could look dangerous. It could look like, oh man, why are they having him do that? It's a foam box that he's hopping up on.
I always make sure to like, everything's a case by case basis. Like,
100%.
I like give the respect to like the coaches and personal trainers that I work with. Like, there's time that they spend with the coaches. Like, I don't know everything that has happened, like in their workouts. Like, I put that trust on them. Like, I trust them to progress them appropriately, and I know that they can do that. So like, if somebody comes back to me and they're like, "Yeah, I was like sprinting the other day and it didn't hurt," I'm like, "Awesome, cool, let's keep going." Like, I don't think that
Are you ever on the inside cringing?
Yeah, I'm hoping at that point that they're like, "Yeah, I ran, it didn't hurt," not like, "Yeah, I ran and now we're at ground zero." It's like,
I ran and everything hurts now.
But yeah, I mean, and like if they tell me that they're like excessively sore after it or something, that's when I kind of like, hey, like, this is how they were, because they don't. With Brandon, the younger athletes, they only work out twice a week. So like there are times where he doesn't see them.
Like middle school and younger, or like elementary school,
middle school, high school. They have some. They have some like 8-9-year-olds in there, like younger kids.
Yeah, just playing.
They're doing like a lot of band work and like just learning how to move, basically.
Yeah,
not a whole lot of high load stuff.
Yeah,
it's like
probably a lot of fun isometrics.
Yeah,
too.
they're always playing dodgeball in there.
Oh yeah,
like
I want to sign up for
at the end. They wrap up with dodgeball. Like he lets them throw the ball at him. It's like it's definitely a fun environment. Like
that, honestly. Are you good moving to like another question?
Yeah,
that's a great transition point. So one of the questions we talked about was weight training for kids, and so like, what are your thoughts on that, and how would you progress? And we can share our
If
things.
you have a kid that is planning on playing sports, there is no better time to start than when they're a kid for strength training. So the goals of strength training change with the age of the kid and with the sport. And having a good strength coach to supervise is the most important part. So obviously don't just go drop your kid off at the gym and say, "Hey, go lift some weights." Potential for injury is really high with kids like that. And like there's research to show like kids can lift heavy and under like good supervision, things like that, they're not going to get hurt. But like I'm more of a fan of like staying away from the heavy lifting and things like that.
They don't need it. Their nervous system's terrible.
Right. They don't need it. They just need to learn how to move. Typically the ones who are lifting heavyweight, they've already been progressed through that. But there's not a huge point to do that when they're at a young age. But kids who do start working out at a younger age typically have better feelings of like self-efficacy. They're more confident in their sport. They typically perform better than kids their age who aren't strength training when it comes to sport. I don't know, did I already say risk for injury goes down? Okay, yeah, so they're less likely to have an injury or a sport-related injury just because they have some of that. Just they're more aware of how their body moves. Like, I mean, everybody's
more coordinated.
Yeah, everybody's been to like a YMCA basketball game. Like for little kids, like my parents have videos of me just running with one arm, like
throwing bows.
Right. But
I like to bring up the importance of, especially when kids are growing super fast, the importance of not neglecting strength training while you're growing, playing a sport, because the potential of losing that key coordination, I think is the chance of losing that even a little bit is too great to discount the strength training that got you to where you are versus just skipping it for a year because you're playing baseball year round and thinking that's going to take you to the next level in 8th grade. You know what I mean?
Right. One of the things that I like, and we did it, a little bit, and we've talked about it. I don't know if we ever talked about it on the podcast yet, but we will now. Is the idea of like, so if you got a younger kid and you're talking elementary school aged, and the idea is you want to, it never happened the way we wanted it to, but if we had a kid, from, all right, he's in 5th grade, 4th grade, whatever, and I get to train him up until they're a senior in high school and how that progression goes. And starting out, very, very basic, the thing is that like strength training, quote unquote, strength training can be whatever it needs to be. Like it doesn't always, I think a lot of times parents hear strength training and they immediately think, power lifters, Olympic lifters, barbell on their back. And that seems scary. Like, and I understand, like he was saying, if you wouldn't just let your kid go run around like crazy and like they do it at Thurston, like what we did and what we do now is having, a program where the kid has a lot of fun, is playing some things and learning how to move. And then as they get older, we used to call it earning the barbell. And we would hold that barbell away for as long as we could. We would do everything we could to using sled drags, using body weight, and using outside weight until they got to a point where they were able to earn the barbell. And usually the only reason we were pushing them, a lot of times in 8th grade, we were trying to get them to the barbell by 8th grade, simply because we knew at the high school, if they were lifting at the high school, they were going to get exposed to that bar. Mm-hmm. And I'd rather have them exposed to it, by me.
Under some supervision.
Quality
supervision.
Right. You've got like 5 people or 10 at the most sometimes versus, like when we were in high school and it's just like there's 90 people in the weight room. You got one coach that may or may not be paying any attention.
I actually, coming full circle, I don't know if I would spend as much time teaching the kids how to do some form of a clean or a snatch. Depending on how much time you want to take to teach that, thinking that that's what they're going to learn whenever they get to that age. If you spent that time and effort where it needed to be with your own program, I almost think that they would be better prepared.
I'm going to have a controversial take.
That's what I kind of thought was going to happen, but that's how I feel right now.
I wouldn't
years
even
ago,
bother. Like if I had full control,
yeah,
I wouldn't even bother with unless they wanted to be an Olympic lifter.
Well, that's not
full
what I
clean,
mean.
full snatch.
Let's say you have no control over their strength and conditioning on the high school level, and you're just controlling their training at the middle school level. That's kind of what I mean.
Oh, I mean,
they're released into the wild. That's what I mean.
I mean, what we did was we tried to do as best we could build robust athletes so that whenever they got there, they were as bulletproof as they could be because we knew that even if. And we found this, like, even if we never talked about. Yeah. Like, I would introduce them to the barbell just so they were used to, like, squat, bench, deadlift. And the things that I felt were the more important. And, and using usually some form of accommodating resistance to build that power and speed so that when they got to the point of being taught how to power clean, they were already a well enough coordinated athlete that for the most part, they would pick that stuff up pretty quickly. And for the most part, they did. Yeah. And if they had technique things when they would come back in and be like, hey, can I get some technique specific work on a clean or whatever we're doing, we would do that and we'd clean up some technique issues and that was fine. Like I didn't bother, very rarely, I don't think we ever did honestly, taught from the ground up like, here's your PVC pipe as a middle schooler, let's throw it over your head like that. Come on now, what are we doing?
I wish that I could if they were younger, but even then, it's like, how important is this one specific thing for you?
Right, the time that it takes to build that, like, can we get more bang for our buck in the time we have doing other things?
You've had experience in the CrossFit arena, right? Mm-hmm. That's
I don't do CrossFit.
Oh, but it's okay. Well, I kind of wanted to ask because I used to do CrossFit. I used to coach CrossFit a lot, and I had so many clients that were nowhere near ready for a barbell, much less some kind of clean or snatch variation, overhead squat variation. But they want to do it so bad So then you're kind of like, well, I'll do the best job that I possibly can as a coach and trying to regulate how much you do of it. And because I've had people that if they want to do a certain thing, how long can you keep them on the leash?
On that note, really quick, and the crazy part is that like, so with athletes and like kids in general, especially like middle school kids, they don't care. Like the parent will come in and I want my kid to barbell clean. I want my kid to barbell back squat. And the kid, most of the time, if they don't have a ton of influence from anybody, could not care less.
Yeah.
They want to have fun. They want to get stronger. They want to get better at their sport, not be better at a specific lift that doesn't have any true carryover. The quality that they're trying to train has a carryover, of course. The outcome has a carryover, of course. But the actual lift itself doesn't have a carryover directly to their sport. And like usually, like you said, you're fighting the parent or you're fighting the the client has in their mind, especially in the CrossFit world.
Yeah, I think some of the like holding people back in CrossFit. I think it like there's the running the business side of things that comes into play. So like you as a coach, like, hey, we shouldn't like load the bar up and keep. Like let this person go when their form's as bad as it is. Yeah. But if you
just keep them off the videos.
Depends on what CrossFit gym you're talking about.
If you tell that person like, hey, you can't put weight on the bar yet, like they're just not going to come back to class.
Right.
And it's a difficult situation to be in. Like you do your best.
It's tough.
Yeah. It's a perfect storm for an injury to happen.
Yeah.
But
goblet squats with a dumbbell or kettlebell are not as cool, not as beneficial.
I found that like if you
there's the like one it's a class setting too. So there's that, social factor where they want to be doing what everyone else is doing.
Yeah.
And so you got to deal with that. And then like there's the just wanting to do the movement that you have to deal with too. So it's hard to tell somebody like you can only tell them that they're not ready for it so many times before they're like, I just don't want to do this anymore.
I always found that balance very, very tough because you want them to have fun, but you also want to you just do the best you can, warn them like, hey, I don't think you're ready for it, but you can do it.
So like the CrossFit gym that I am based out of, I was like talking to her about like just mobility work one time, and she was like, yeah, like I used to have classes for mobility, like they were just mobility classes. Yeah. And they were just eating up time slots because nobody would come to them.
So it's even though it could be very important to do,
nobody wants to do the
homework,
the prehab. Really, like I think this is just Americans in general. We're very reactive when it comes to our healthcare. Yeah. Like we don't do the things to prevent stuff from happening. We want people to take care of us after it happens.
Yeah, and super fast. Like, it's going to take 12 weeks, not 6. You don't necessarily think that the advice you're being told is valid until you really need it. I get that. And I don't want to do the mobility work because I don't need to do it. But you think that I do, that's an extra, whether it's 5 or 10 minutes before a workout or on your off days or when you're sitting down on the couch and watching TV when you're not doing anything anyway besides maybe having a drink or popcorn or,
that's your relaxing time.
Yeah. Right. You could relax on the floor and do your mobility.
That's the thing that like blows my mind is just like if you don't take the time now, like your body will force you to take that time at some point. Like it's pay now, pay later, and it's like, man, if you just do a little bit now, you like get to like not have to do any of that garbage later.
I like the quote, learn from your failures because your body does. It's very true.
Yeah. I feel some of my failures when I wake up in the morning sometimes. There are some of those, that was a bad idea. Yeah, no, definitely. Thank you for tuning in to this episode of PRTyCast. Check us out on your favorite podcasting site. And remember, each episode is also available on YouTube. Thank you for joining us on this adventure, and we will see you next time.